Hello and welcome to the EduTalk Diabetes Series, hosted by Easy, Biotone, and diabetes health and wellness experts. With the daily challenges of diabetes and interest in health and wellness strategies, the EduTalk Diabetes Series supports building your wellness community by connecting you with diabetes health experts who share their knowledge and expertise on topics of concern to provide you the tools and resources to support and manage a healthy lifestyle. Today's expert is Nathan Lesch, the lead nurse practitioner at Intellihealth. He's a seasoned family nurse practitioner specializing in diabetes and obesity care. With 16 years plus of healthcare experience, Nathan excels in managing complex metabolic health conditions, driving digital transformation, and improving patient outcomes. He's renowned for his commitment to quality improvement and innovation in care delivery. Let's listen and learn as Nathan discusses how diabetes significantly impacts cardiovascular health, increasing the risk of heart disease and blood clots. Nathan will explore the intricate relationship between diabetes and cardiovascular complications, focusing on prevention strategies, early detection, and effective management to reduce the incidence of blood clots and improve overall heart health. Again, thank you for joining us. Be sure to have your sound muted and video off, and as well as chatting your job titles. Feel free to chat questions and comments during Nathan's presentation, which he'll answer at the end. And with that, welcome, Nathan. I know we have a lot to get to. I am going to exit the screen. I'll see you on the other end. And thank you so much for sharing your knowledge with us today.
Great. Thank you so much, and appreciate the intro. Let me go ahead and share my screen. There we go. Thank you, Danelle. So as you mentioned, I'm the lead nurse practitioner. I'm also the director of clinical operations for Intellihealth and Flight Health, which is a telemedicine company that specializes in the treatment of obesity. We see patients from all over the country and have a great team of nurse practitioners and physicians and registered dietitians on staff that we help coordinate care for. A little bit about me: I was a bedside nurse in the medical surgical departments, ICUs, ERs, kind of all over for 7 years. I went back to school, got my master's degree from Texas Health Science Center in San Antonio, and became a family nurse practitioner and started working with my mentor, Dr. Carlos Campos in New Braunfels, Texas, where I got passionate about diabetes, which then kind of drew me into obesity medicine as well, because that's kind of really parallels with diabetes and affects a lot of the same aspects in the patient. And so those are my two passions. And now I transitioned to Flight Health, where I lead the kind of clinical operations for them in their treatment of obesity medicine with our patients. But diabetes is very much a part of what we do as part of our ongoing care for patients as a kind of a holistic approach. And so today, our conversation is really going to be about diabetes and heart health, blood clots and cardiovascular disease, and how those different pieces kind of fall together. Sounds like we have some clinicians in the audience, maybe some other folks that are more lay folks that may just be here for education. So I'm going to kind of give a general overview on some of these topics, so we can go to the agenda here. Talk about diabetes, kind of what that is. Talk about cardiovascular health, how that plays a part of diabetes and puts folks with diabetes at higher risk. And then what specifically blood clots are, how we can kind of do what we can do as patients to prevent these cardiovascular complications from occurring, some of the early detection methods that may be used from a provider standpoint, but then also effective management and prevention treatments from a provider standpoint of how we can help kind of reduce the risk, what's the most up-to-date treatments strategies, and then talking about the role of some diet and activity or exercise, and then opening it up to more questions and concluding there. But yeah, excited to be here and looking forward to kind of answering any questions you may have. So hopefully if you came here with questions, please jot those down in the chat now, or as things arise, as you're listening to the overview, the PowerPoint, as we go through, you have questions, concerns. I really want to make sure that at the end we have time to really kind of dive into any questions that folks have. And really that's my favorite part, just to be able to interact with folks and ask any questions that they may have. So, well, let me talk a little bit about kind of, what is diabetes, right? So we have, three main types of diabetes. Gestational diabetes, which occurs during pregnancy, type 1 diabetes, which has traditionally been diagnosed in childhood, but we are now knowing that there are latent autoimmune diabetes of the adult that occur. And then there's type 2 diabetes. And so with type 1 and type 2, the real differential is, what is the cause of the elevated blood sugars, right? In type 1, the pancreas is not producing enough insulin to meet the need of the patient who is having, in response to their glucose. Whereas type 2, the pancreas is producing insulin. However, the insulin is not being taken up and utilized in the cells in the body appropriately, and we have insulin resistance, which therefore then the blood sugar starts to rise that way, right? So one's a case of there's not enough insulin. One is there's enough insulin, but it's not working appropriately in the body, and that's kind of the differential. And then gestational being diabetes that we catch during pregnancy, and it's just a byproduct of kind of the stress of the pregnancy. And so there's screenings that occur in women that are pregnant to catch that and manage that during the pregnancy, so that both the patient and the baby are healthy. Usually that's with a 2-hour glucose, oral glucose tolerance test, excuse me. We know that diabetes is on the rise. About 10% of the population have it. There's even more, somewhere in the range of 30% of folks we don't know, or they don't know that they have it. They may have prediabetes or undiagnosed type 2 diabetes. And so really important that we're screening folks with checking for blood sugar, A1C, and cholesterol and blood pressure readings, and we can kind of get to that in a little bit. But the cases are rising along with the cases of obesity, and so we see those two parallel epidemics kind of going hand in hand, where we have an opportunity to really improve and reduce the risk of developing type 2 diabetes or cardiovascular disease. And really that's by doing some great preventive strategies. And weight is a great place to start, because we know by treating our weight, we can improve blood pressure, we can improve cholesterol, we can improve blood sugar readings and reduce insulin resistance, and really have a beneficial impact on kind of the cascade of things that happen down the line as time goes by. So how does diabetes relate to cardiovascular disease? Well, we know that when glucose or sugar in the blood raises, it has an inflammatory effect. It damages blood vessels. It causes increased risk for clots. It can also reduce and damage nerve endings, and reducing sensitivity, whereby you may not feel that you have some pain or inflammation in the area. And so that chronic inflammation leads to potential for increased plaque to develop in the arteries and the vessels of the body. That plaque can narrow the blood flow to areas, putting them at risk for peripheral vascular disease, right? Those black plaques can break off and travel to the heart, where we have a myocardial infarction or a heart attack. If they are in the veins, they can travel up and develop into a PE, or stay in the veins and cause just a deep vein thrombosis or a blood clot. And the change that that occurs is that as the time that the blood sugar is high, that damage is where you see the most risk, right? So we really think about time in range as a big factor in how we manage folks with diabetes. And the time in range is talking about how much time in a 24-hour period is that blood sugar in a healthy range. We typically define that as 80 to 180 as the range in which the blood sugar, we want to kind of keep it in as often as we can to have the least impact on cardiovascular disease or prevention of cardiovascular disease, prevention of other complications associated with sugar. Sugar is helpful. We need that glucose in our bodies to fuel our muscles and fuel our metabolism and all the different pieces of a day-to-day function. But when the blood sugar increases past 180 milligrams per deciliter, that's when we tend to see some of the chronic inflammation and changes occur that put us at higher risk for cardiovascular disease. Blood clots kind of similarly have a very healthy function, right? We need blood clots to develop to heal parts of our bodies when we have cuts and have different injuries occur. However, with the chronic inflammation that can occur with uncontrolled diabetes, we see a malformation or just inappropriate increase in clotting that can turn into deep vein thrombosis or what we call a blood clot. And those blood clots can also break off and travel into the heart and get pushed into the lungs where they become a pulmonary embolism. So some of the common symptoms of blood clots that you want to be aware of is, if you're having swelling in your leg, usually it's one-sided, it's one leg, it's unilateral, and it's usually in the calf or the thigh, and that area or appendage will be swollen. It'll be potentially red, warm to the touch, and be painful. Typically with activity, walking, movement, you'll notice pain to that area as you're ambulating around, and it happens usually sudden, although it can happen kind of gradual too. So that's why we really want to make sure that folks are assessing their legs, assessing their feet regularly, daily, looking for changes that have occurred in folks with diabetes to kind of confirm or to assess for any risk for blood clots. And with folks who have that are not as mobile, we know that blood clots can occur more readily. People who are chair bound or bed bound, people who have smoked or who currently smoke, risk factors like that, and folks who have increased weight. So if your weight is elevated, you are at higher risk for blood clots as well. And so being aware of that can be very helpful, and knowledge is power, and we can utilize that to kind of help just, change behavior, either in terms of what we're doing with our activity or our eating, but also make sure that we're getting the preventative screenings and getting in to see our provider and kind of doing that self-assessment, when you're in your day-to-day as well, to say, so if you see something, kind of say something to your provider about the different pieces that may be changing, right? Some things are normal as we age, our bodies are going to change, but some things may not be. And so noticing if there's swelling that occur that wasn't there before, pain that occurs in the lower extremity that wasn't there before, or redness, swelling, some of those things. Obviously, more severe cases, you're going to have difficulty breathing, chest pain, and that's going to be more indicative of a pulmonary embolism, in which you'll want to, that's an emergent situation, you'll want to call 911, you'll want to go to the ER and be assessed for that. But generally speaking, most blood clots start as in a lower extremity, swelling, redness, pain, and we can talk about some of the prevention strategies here now. So prevention strategies, we know that healthy eating has a huge impact, not only on our glucose control, but it has a huge impact on our weight, on our cardiovascular risk, and inflammation as a whole. The foods we eat have a huge impact on our inflammation. We know that foods that are high glycemic index, things that cause our blood sugar to spike more readily, cause inflammation. They're inflammatory foods. And so when we think about really refined, processed sugars and grains, those are the foods that typically have the highest glycemic index, cause our blood sugar to spike up, and our insulin levels to spike up, and our inflammation therefore to be elevated, right? So the strategy is really to reduce those highly refined grains and sugars as much as we can. Another strategy to utilize is to eat the protein and the vegetables in the meal first, right? So if you have a plate of food, if you have chicken, broccoli, and rice, if you eat the broccoli and the chicken first, one, you'll fill up on those foods because those are high protein, high fiber, right? Foods. You'll fill up faster. You may not eat as much of the rice, but when you eat the rice, by eating the chicken and the broccoli first, the protein and the vegetable first, you'll absorb less of the calories from the rice, and therefore your blood sugar will not spike as high. And so that's what we call meal order. And it's been really shown both in the research and with the advent of continuous glucose monitors that is a great strategy for folks, whether or not they have diabetes or not. We utilize this strategy for folks who just want to lose weight because it reduces their blood sugar spike even minimally in folks that don't have diabetes, right? So it's a great strategy, whether you have diabetes or not, to think about the order in which you eat the food. We typically go to restaurants, we have some breadsticks, we have some, appetizers that are high in carbs. But if we can kind of wait on those and do the higher protein, higher fiber foods first, save the carbs for last, you're going to notice less. You're gonna maybe eat less of them because you're filling up on those proteins and vegetables first, but your body is gonna absorb less of those calories. You'll lose more weight as a byproduct of that. So it's really more of a weight loss thing, but it also helps with blood sugar control. And then we talk about what types of foods really have kind of a beneficial effect at heart health. And we know vegetables are really great key staple, and fruits as well. However, we know that fruit has a lot of fructose, natural sugar. And so we want to think about strategically when we eat those foods, right? Earlier in the day is better for some of the fruits because we're going to be utilizing, we're going to be working, we're going to be doing things that we're going to utilize some of those sugars, those natural sugars that come from the fruits. And later in the day may not be the best time to utilize a bunch of fruit, but we think of it as a continuum, right? There's not a good food, there's not a bad food. There's just a kind of a continuum of better, worse, and all those things, right? So, if we have to choose between a sugary candy or a fruit, obviously the fruit's going to win because it's got more. It's natural. It doesn't have processed sugars, and it has more fiber. And when you have foods that have fiber, you're going to have less of a blood sugar spike in general, right? Same thing with whole grains. Whole grains, which are like brown rice, brown or wheat breads, whole wheat breads, quinoa, couscous, things that are more complex in nature. Grains have more fiber, and those fibers help kind of blunt the insulin response, the blood sugar response. And so you're going to have less of a spike in your blood sugar, less risk for weight gain, blood sugar increase, but also inflammation, right? So those are things to kind of consider. We know in terms of the physical activity that the amount of activity is helpful, but we don't want to get too caught up on the timing, right? I think the best thing is to think about moving more, whatever that means for you, whether that's, just starting by walking a little bit once a day or once a week, or you're already kind of fine-tuned and now you're walking every day or doing something every day, kind of increasing the resistance, right? But think about small kind of sustainable solution, small sustainable goals, and kind of think about increasing as time goes by. We know that cardiovascular activity or aerobic activity, walking, swimming, cycling, are great for heart health and for cardiovascular risk reduction, but also for keeping your blood sugar stable. We also know that resistance activity can be really helpful for insulin sensitivity and keeping your body's insulin more regulated, but also allow your blood sugar to be more stable because of that. So we do recommend 150 minutes of activity, 1 or 2 days a week, trying to do some resistance activity on top of that. And we typically recommend, yoga, Pilates, body weight strength. Doesn't have to be lifting heavy weights, right? People think resistance activity has to be heavy weights in a gym. You can do this at home. YouTube have some really great yoga videos you can follow along with, 10 minutes, great body weight strength videos you can follow along with. But as we age, our muscle mass declines, and as we age, our insulin resistance gets worse. And so doing that physical activity really helps kind of keep your insulin levels more stable, keep your blood sugar more stable, and help your heart. Obviously, we want to get being checked by getting our blood pressure checked, our heart, listen to cholesterol levels, blood sugars checked regularly, and then taking medications as prescribed by the provider, and making sure that they're doing what they are intended to do, right? So checking your glucose, checking your blood pressure, and letting your provider know if you're having side effects or concerns with the medication that you're taking, right? In terms of early detection, there's a lot of different things that may occur, but with folks with diabetes, we do want to make sure we have an annual or a regular ECG, electrocardiogram, on record. If that's abnormal, we want to make sure that you're getting seen by a cardiologist to get that worked up. And if any new symptoms of chest pain, shortness of breath, or fatigue, we want to do an ECG because we want to have a higher level of consideration for folks with diabetes when it comes to those kind of symptoms, because we know that they're higher risk for cardiovascular disease, right? When you meet with the cardiologist, they may do a stress test, which is another term of an exercise ECG, where you're on a treadmill and they have you hooked up to the monitors to monitor your heart, or a nuclear stress test where you're given a medication, they kind of stress the heart with the medication, and they can see kind of what that response is on the ECG. They also may do an echocardiogram, which is an ultrasound of the heart, to look for how the valves and the heart is working and how much pump or ejection fraction your heart is giving with each contraction. Coronary artery calcium score is a modified CT scan of the heart that looks and measures the calcified plaque in the arteries, and it's scored from 0 to over 300, and 0 is best. That means there's 0 detected coronary calcified plaques, whereas over 300 is high risk. And so, that is a great kind of screener, but it doesn't tell us the whole story. So it's only calcified plaque. There can be non-calcified plaque that's existence that doesn't show up. And so just another tool that we can use. And then the ankle brachial index is checking the pressure in the arm, comparing that to the blood pressure in the ankle, and seeing what that level is and what the difference is. And if it's high, that tells us that there's potential risk for narrowing in the arteries of the leg. And then that needs to be kind of further worked up with ultrasound, Doppler, and a vascular specialist. But we really recommend that for anybody over the age of 50 who has diabetes or is at high risk for peripheral artery disease, smoker or long-term smoker, particularly. And then if they've had any complications from their diabetes in the past, whether that be, neuropathy, retinopathy, nephropathy, those folks all definitely need ankle brachial index. Oftentimes primary care can do that. If not, definitely the cardiologist can do that. And so you want to make sure that your PCP is referring you on for that, or you're advocating for that to be part of your assessment, right? So what do we do with folks who have diabetes to prevent cardiovascular disease? We really kind of set the ADA, the American Diabetes Association, in combination with the American Academy of Clinical Endocrinologists, really set some really good guidelines for what we should be targeting for blood pressure, heart rate, and the blood pressure, generally speaking, should be less than 120/80. We know from the Sprint study that came out not too long ago that lower is better. Used to be less than 140/80, and then for a while the ADA had said less than 130/80, and now The consensus is really less than 120/80. But again, that's going to be a conversation that you're going to want to have with your primary care provider or endocrinologist, whoever's managing, or cardiologist, whoever's managing your diabetes and prevention of cardiovascular disease. But generally speaking, that's what we're shooting for, and that's sitting down, resting, and the heart rate, same thing. We want it to be within a range of about 60 to 100. Less than 60, you want to let your provider know. Reach out to your PCP, particularly if you're having symptoms. And then if you're resting, sitting down, your heart rate's over 100, that could be signs that your heart is getting stressed from other conditions that could be occurring. And so you want to let your provider know about that, right? The glucose or the blood sugar level, your average A1C, so the average blood sugar for the last 3 months, we want that to be less than 6.5. The ADA has said it's kind of less than 7, but we know lower A1C is better. For every 1% A1C reduction, we reduce your risk for cardiovascular disease, retinopathy, nephropathy, neuropathy, and cardiovascular disease by 33%. So lower A1C just translates to better risk reduction. So that's something that you would want to be checked every 3 months if your A1C was over 6.5. If it's less than 6.5, we usually check it every 6 months. Fasting glucose, which is the morning blood sugar that you check when you wake up, we want that to be less than 100 milligrams per deciliter. And the 2-hour postprandial glucose, less than 180. So you eat your lunch, 2 hours after lunch, you check your blood sugar, that level should be less than 180. And that's where we kind of get that 180 to 80 range for our time in range, right? So the majority of the time in our day or 24-hour period, we want that glucose between 80 and 180. For optimal results to kind of keep your risk low for cardiovascular disease and other complications associated with diabetes. The lipids, the low density lipoprotein, or the LDL, also known as the bad cholesterol, we want that less than 70. If you've already had any cardiovascular complications, previous heart attack, previous stroke, any limb concerns, peripheral vascular disease, we want that even lower, 55. But LDL generally for folks with diabetes less than 70, HDL greater than 50, triglycerides less than 150, and total cholesterol less than 200. And I share this because I think it's really important for everybody to know this information, not just the providers, but for the patients too, so they can talk to their providers and say, hey, I'd like to get my cholesterol lower based on the American Academy of Clinical Endocrinologists. It says I should have my LDL less than 6. So I really encourage folks to look at these numbers, take these home, compare them to their own numbers, and then talk to your primary care, your endocrinologist, cardiologist about kind of optimizing the numbers, because it makes a big difference. And I think everybody's trying to do their best, but it's really helpful when patients are empowered with the knowledge to kind of help make those decisions in terms of their care as well. And then weight. So that's kind of my specialty in addition to diabetes, is that we know obesity is a chronic condition. There are over 200 genes that regulate our weight. There's over 24 hormones that regulate our appetite, hunger, cravings. And we think of it as a chronic condition, right? So it's really important to partner with somebody who's trained in obesity medicine or has that understanding that it's a chronic condition that requires some lifestyle intervention, some diet, some exercise, but also medication intervention. Just like we treat blood pressure and cholesterol and blood sugar with meds, we have medications now that we use to treat weight. And with obesity, it's kind of stratified out into classes. And not that we would move somebody from class 3 all the way down to overweight, but that we would slowly over time, gradually and safely and effectively lower their weight with a combination of strategies. And we know that as the class of obesity goes up, as those BMI numbers go up, the higher risk there is for cardiovascular disease, but other conditions that are associated with our weight. Okay. So the role of diet and exercise, the American Diabetes Association still encourages the DASH approach, which is the dietary approaches to stop hypertension, which is essentially just reducing the sodium, increasing potassium, reducing alcohol, increasing activity, and smoking cessation. And some of the strategies I've kind of outlined there in terms of sodium reduction of less than 2 grams a day, increasing the fruits and vegetables 8 to 10 servings, so kind of quite a bit, and then reducing saturated fats, trans fats, increasing the fiber to 20 grams or more a day, and then limiting alcohol. And then obviously the physical activity, increased activity, we really want to think about just moving more, right? And so I talk to my patients about, small goals, like I said, but activity as anything, right? It could be parking further away in the parking lot. It can be taking the stairs instead of the elevator. It can be, any activity, standing up at your desk. Those are all activities that have a huge impact over time and have some really good research behind it, that just moving more in general can be super helpful for reducing your risk for cardiovascular disease, keeping your blood sugar more stable, keeping your blood pressure more stable. A study came out that showed that sitting is now the new smoking in some respects, because it's been tied to so much our sedentary jobs and activity levels have declined so much that it's very similar to what we saw with smoking. And now we need to start moving more now that we've kind of cut down our risk of, folks smoking, which is great. So kind of a medication overview. We have a lot of things that we use as providers to help folks who have a history of diabetes or have diabetes reduce their risk for cardiovascular disease. Metformin is kind of the staple medication that we've used since the 1950s. It's a derivative of the French lilac plant. It's been a great medication for prevention of diabetes. We use it as a weight loss medication. We use it as medication for fertility. So there's a lot of variety of treatments we use that for. But it's been shown in the UK-PDS trial that it reduced the risk of cardiovascular disease 30%, which is great. And it's been a staple that we've used with diabetes forever. So it's really something that we recommend patients with diabetes be on, unless there's concerns otherwise. The SGLT2 inhibitors and the GLP-1 receptor antagonists are newer medications, but have also had a lot of great research in the last 10, 15 years showing that they have not only help with blood pressure and help with glucose control, but also help lower blood pressure, lower weight, have effects on our kidneys, and really improve our risk and reduce our risk as time goes by. So the SGLT2s, there's 6 on the market, 4 of which have shown to have cardiovascular disease risk reduction. Some of which are FDA approved just for heart failure, and not even for diabetes, by itself, and diabetes as well separately, right? So that's how effective those medications have been. That's Invokana, Jardiance, Farxiga, Inpefa, and then there's Benzamvi and Steglatro. Those are the brand names. The GLP-1 receptor agonists you may have heard a lot of, Wegovy, Ozempic, Zepbound, Mounjaro. There's also kind of the Victozas, the Saxendas. Wegovy, or the semaglutide class, has been FDA approved for reduction of cardiovascular disease after as a secondary prevention if someone's had cardiovascular disease. And they're coming out with more studies, ongoing, but we're seeing that more of these medications are helpful for significant weight loss. With the tirzepatide's 22%, with semaglutide 15%. So really effective at helping people lose weight, but also control their blood sugar, reduce their cardiovascular disease, and improve inflammation levels, right? Aspirin used to be seen as something that we put everybody on. Now it's kind of controversial recently, but it's still something to think about and discuss with your primary care provider or cardiologist or endocrinologist about whether that's a good option for prevention. With folks who've had heart attacks or strokes or blood clots in the past, they oftentimes do recommend still aspirin as a strategy to prevent recurrence. It can be considered as a first-line prevention strategy for those with diabetes and high risk of cardiovascular disease, but it really needs to be a conversation that you have with your provider. Okay. Statins, lower cholesterol significantly have been shown to reduce the risk of heart disease, and it's a staple for those folks to prevent cardiovascular disease who have diabetes. So if you have diagnosed diabetes and you're over the age of 40, we do recommend you are taking a cholesterol lowering medication like a statin, so Crestor, Lipitor, Zocor, all of the cores and statin medications. to reduce the risk of cardiovascular disease. That lowers your cholesterol, lowers your inflammation levels, the C-reactive protein level, and reduces that risk for heart attacks, strokes, and cholesterol to build up in the arteries. ACE inhibitors and ARBs, that's the blood pressure medications, angiotensin receptor blockers, and ACE angiotensin conversion enzyme inhibitors are the two medications that we use. And we use those for folks with diabetes who, as a prevention strategy for keeping their blood pressure stable, reducing the risk of cardiovascular disease, but also improving and protecting their kidneys. And so the SGLT2 have also been shown to reduce kidney disease. And so they both lower blood pressure. And so we've been using both options. Oftentimes you'll be on an SGLT2 inhibitor and you may not be able to be on an ACE or ARB because your blood pressure is too good, and you don't need that additional support. But ACEs and ARBs are, lisinopril, ramipril, all the prils and all the artins, losartan, olmesartan, valsartan, medications have been around for a while, but have shown to be really helpful and highly studied to reduce the risk of cardiovascular disease, particularly in folks with diabetes. And so we use them as a prevention strategy, not only to help with blood pressure management, but prevent cardiovascular disease, and then also kidney protection, like I said. So these are things to think about, and talk with your primary care provider, endocrinologist, cardiologist. Make sure that if you have diabetes, you're on these medications or are considered for these medications if appropriate for you, and you know that they're available, right? But yeah, in conclusion, there's a lot of things we can do. I think the research is more and more coming out that there's a lot of great opportunities for ways for patients to partner with their provider. We at Flight Health specialize in obesity medicine, and so we look at all these pieces as part of the patient's journey with their weight, and we look at all of these pieces: their blood pressure, their cholesterol, their inflammation levels, their insulin levels, and we have a conversation with them about what we can do to kind of improve these numbers over time, looking at a holistic approach, but understanding that our weight is a complicated, complex thing that really requires strategic medication in combination with some healthy eating, some healthy activity. And so we approach it very holistically in that sense. So love to take any questions people have about any of the conversations from today. And Donnell, I'll turn it back over to you.
Thank you, Nathan. Lots of information. And quite simply, when you were speaking about the aspirin, I remember hearing that baby aspirin was something you should take every single day, but then I think over the last year or so, that's become more controversial.
Yeah, that's a great question. So there was a big study that came out that showed that, the risk benefit, it's a blood thinner. And so when you have everybody taking blood thinners, not everyone gets the benefit because there's a certain subset of the population, those over 65, that have a higher risk of falls. And those falls, when you're on a blood thinner, can turn into kind of worse outcomes, right? And so they revised some of that language to say that really folks, between 40 and 65 may benefit from an aspirin, baby aspirin, 81 milligrams, somewhere in that place, but enteric coated, right? So aspirin comes in a lot of different variations. If you just take aspirin plain, it can kind of cause irritation of the gastric lining, of the stomach lining, and so you can get ulcers from taking aspirin. So the enteric coated aspirin is better formulated, so it bypasses the stomach. It doesn't get absorbed in the stomach, but it goes into the intestine, gets absorbed there, so you don't develop any ulcers. And for those ages 40 to 65, they have less risk for falls. They have more risk for potential for heart attacks and strokes. That's when we see majority of folks develop heart attacks and strokes, is in that age range of 40 to 65. And so that group specifically could be considered a good group for an aspirin. But again, want to just discuss that with your primary care provider, your cardiovascular specialist or endocrinologist before just popping an aspirin is what I usually recommend. Yeah.
All right. And we have for GLP-1 meds. I'm not sure with the PT who are taking it for weight loss only, thoughts on data and maintenance dose.
Yeah, great question. So the GLP-1s, just for everybody else, are those injectable medications like Wegovy, Ozempic, Zepbound, Mounjaro, Victoza, Saxenda. Those are all injectable, and there's oral Rybelsus, right? So those medications we use they're both FDA approved for diabetes. They're all also FDA approved for obesity, for weight loss. And we use them to help people lose weight, but we don't stop them, right? So that's the kind of common misconception, I think, for a lot of folks, is that we're going to use these medications to help people lose weight or control their blood sugar, and then we're going to stop the medication. Unfortunately, no. So just like with high blood pressure, high cholesterol, we're going to use those medications to control the underlying condition, the weight or the blood sugar. And once the blood sugar is controlled, or once the weight is controlled, we're going to keep folks on those medications long term to lock in those results, right? The benefit of treating the weight, though, is that yes, you can come off your blood pressure medication, you can potentially lower your cholesterol medication, right? Because as we know that when our weight comes down, our blood pressure comes down, our cholesterol comes down, and we may not need as much intervention or the same amount of intervention. The goal is going to still stay the same. So if you have diabetes and you struggle with your weight, your LDL level still goal is less than 70. And so you may not need the same level of a cholesterol lowering medication. You may not need 20 milligrams of rosuvastatin. You may only need 10. You may need 5. Or maybe you may be able to come off of it completely, right? As long as your LDL is less than 70, right? So that's the benefit of treating weight in the setting of having other health conditions like diabetes or high cholesterol, high blood pressure, is that by treating the weight, you lower the other conditions, potentially reducing those medications. In terms of the maintenance dose, yeah, we can reduce the medication that we're using to control the weight too, right? So when folks, are using Wegovy, we'll say, we can titrate that medication up, and as their weight comes down, they may not need the same level of medication intervention that they did when they started, or to maintain that weight. Because as we lose weight, a lot of things improve. Our energy improves, our mood improves, our ability, our capacity for exercise improves, our pain improves, right? So when every 1 pound we take off of our weight, we take 5 pounds off our knee joint. And so that has a huge impact on people's lives. And so when they start their weight loss journey, they may not be able to move as much as when they are using these medications. They get their weight down, they're moving more, they're feeling great. And so then we don't need to necessarily use the same level of medication in terms of the GLP-1s that we're using. So yes, we do scale those down. Everybody's journey is a little bit different. Not everybody, there's not really we don't do a one size fits all. We use a very individualized approach to our care. And so one person's maintenance dose may be a different for somebody else and somebody else, right? But yeah, there's oftentimes we have to reduce the GLP-1 that they're using. And oftentimes we can reduce and have them come off the medication, but it still requires constant kind of, touching, right? So either stepping on the scale, continuing to stay active with their lifestyle, eating healthily, those types of things. But I would say the vast majority, 80+% of folks are going to need medication long-term for their weight. And because the reason behind that is, as our weight goes up, our body sets that highest weight as the new normal, okay? And so it makes it very difficult for us to lose weight once our weight goes up, because that's the new normal. So when we lose weight with diet exercise alone, oftentimes you'll see the weight go back up because our body wants to kind of get it back to that higher weight, right? So that's called metabolic adaptation. And so when we restrict our eating, when we increase our activity, our body recognizes that the weight's coming down and says, no, 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 I want to go back up to the weight that I was before. So it's going to turn up the hormones in your body that make you feel hunger, that make you less satiated. And it's going to slow down your metabolism. And so that weight kind of rebounds. We see this happen with patients who had bariatric surgery, right? When people have part of their stomach removed, they lose a significant amount of weight over time. And they may stay down for a long time, but over time, and I see this every day, patients come to me, have had bariatric surgery, lost 100 pounds, and then regained that 100 pounds, or regained half the weight that they lost, or even they're now higher than they were prior to the surgery, right? And that's because our bodies are really, stubborn at wanting to keep that weight at that highest set point, right? And it's nothing that the patient's doing wrong. It's nothing that's anything that they're doing. It's their body working against them, right? And so that insulin resistance, that metabolic adaptation can all kind of work against this as we try to lose weight and that weight come back up. And so that's why we think of it as a chronic condition. That's why we use medication in combination with some healthy eating, some healthy activity to allow for slow, steady weight loss that's sustainable, maintainable, and reduces the risk of other health conditions, right? Reduce the risk for cardiovascular disease, reduce the risk for conditions, health conditions associated with their diabetes, reduce their blood pressure, that kind of thing. But great question, yeah. Other questions about any of the
I'm not
topics?
seeing other questions come in, but it is amazing to me, and everyone, we still have time for more chat questions. The amount of diabetes related television commercials that are on. I mean, it's in a half an hour, you might see 3 different commercials. It's confusing, it's eye-opening. I'm for someone who doesn't have diabetes, but it is really the most prevalent commercials that I see on television.
Yeah, we're really yeah, it's a really fascinating time in endocrinology and obesity medicine, just because there are so many new medications that are coming out, that have come out, that also have multiple indications. It's kind of unique. At least before, it wasn't as prevalent that you'd have a medication get so many different FDA approvals under this, at the same time or around the same time for different indications. And we're seeing that. So with Jardiance, right? You see a lot of commercials for Jardiance. Jardiance is FDA approved for reducing the rate of kidney disease in patients with diabetes, reducing the cardiovascular rate of complications associated with diabetes, and then just for diabetes. So it's got 3 different indications. Same with Farxiga. Invocan is coming out with it has already 2, and they're coming out with another one. So there's a lot of activity in that space, and there's a lot more. There was just 1, and now there's 6. And same thing with the GLP-1 class. There was just 1 or 2, and now there's 7. And there's the whole pipeline of new medications coming out to the market specifically for obesity, but have other indications. So reducing the risk of liver disease, reducing the risk of cardiovascular disease. And so it's really a neat science that we're kind of in right now, where we're having all these opportunities and different tools in our toolbox to help folks.
Yes, and it can be overwhelming because there's, as you say, it's just the start of more drugs coming on the market.
Yeah.
And then, working with your healthcare provider to find actually what is the best benefit to the individual. Well, I would like to, I haven't seen more chats come in, but I would like to let everyone know that tomorrow you'll receive a follow-up email, and it will include Nathan, recording of Nathan's EduTalk tonight. It will include a copy of his PowerPoint presentation and his contact information, so that if you have further questions, you can reach out to Nathan directly. Also, I'd like to mention that November 12th is the last EduTalk Diabetes of the year. And we have aromatherapist Jennifer Presimone presenting on navigating the emotional journey of diabetes with scent. And she has previously presented for the EduTalk massage series on aromatherapy. I also want to say that in the EduTalk Diabetes Archive Library on ease-z.com, Nathan does have a previous EduTalk there, and he will be presenting again in February 2025, coming right up. And I will include a link in the follow-up email tomorrow to Nathan's previous talk as well. Thank you, Nathan, for joining us tonight and sharing such, to me, in-depth information. And yet, within it, just some very simple, practical things that all of us can do to improve our health, our overall health, from, just simple walking. So I thank you for that and sharing your information. I thank everyone for joining us tonight for the EduTalk Diabetes series. And please watch your inbox for the follow-up email. If you do not see it by tomorrow afternoon, please check your junk or spam folder. And with that, everyone, be well, be safe. Thank you, Nathan, so much. Looking forward to working with you again in 2025. And take care, everyone. Thank you.
You.
Bye-bye.